Thank you all for joining us. This week we're talking about field hospital setup and SARI treatment center setup, as well as Nigeria's response to the COVID-19 pandemic. We have Dr. Idowu Olajide, who works for Pelon Memorial Hospital in Lagos, Nigeria, and works as a consultant practitioner, works as the head of the emergency department there, and is also part of Nigeria's COVID-19 response team. Dr. Idowu Olajide, who will be presenting on Nigeria's COVID-19 response.
Okay, I'm Dr. Idowu. I'm a consultant general practitioner from Pelon Memorial Hospital. I'm the head of the emergency medicine department of Pelon Memorial Hospital, and I need to also mention that Pelon Memorial Hospital started of a private COVID isolation center, which is a public government partnership that was started last week. And we're actually in our second week of this, and it's quite a learning curve for us too. So I'm here to present the COVID-19 Nigeria's response and the challenges that we faced. In my outline, I have the Nigerian healthcare demography and health infrastructure, Nigeria's COVID-19 statistics, Nigeria's response to COVID-19, the challenges that we face, the people, the health system, and the government, what the experience has been for the clinicians, and the conclusion overall. As you can see from my slide, Nigeria is a multicultural country. We have a land mass of is about 923,768 kilometers square, and we are the most populated country in Africa. We have about 200 million people with a population density of 212.04 individuals per square kilometer. We are a lower middle income in terms of our health infrastructure, we have about 80 hospital beds per 100,000 population, which leaves us at a ratio of 1 bed to about 1,250 people. We have doctors per population of about 36.3 doctors per 100,000 population, which means a doctor will probably have to see about 2,753 people. The nurses population, we have about 83.1 nurses per 100,000 population, which leaves it at about the nurse to population ratio of 1 to 1,135, and 58.9 midwives per 100,000 population. And this leaves us at a ratio of 1 to 1,797 to a nurse. I also need to mention that for the nurses and midwives, some of these nurses also are the midwives because they have double qualification. So the ratio may not even totally be as it is looking right now. We have the ICU beds. I cannot directly really say this is the total number of ICU beds we have, but there was a journalist publication that showed about 350 ICU beds nationwide. That was as at March, when the COVID-19 cases started to increase. I'm sure we should have about 400 now nationwide. The emergency medical services system in Nigeria is not the best right now. It has not been the best always. We don't have a standard emergency medical services system. Some states have been able to establish, like Lagos State, where I currently practice, we have an emergency medical service, but this is also still inadequate for the kind of population that we have. I'm sure a lot of Nigerians don't even know the emergency medical service phone number. The total infection of confirmed cases stands at 13,873 confirmed cases as of yesterday. We have total tests done of about 82,935 samples have been tested. And the total number of deaths is 382 confirmed deaths from COVID-19. And during the period of testing, from test confirmation to discharge of patients, we have about average of 3 tests done per patient. Now to the Nigeria's response to COVID-19. When COVID-19 started globally, one of the things that Nigeria quickly started off was the public health awareness system through different media, and where we had different talks on health education in order to meet at different levels. The health education was made in such a way to meet different languages and different tribes so that people could understand what exactly was happening. There were leaflets all around and newspaper publications and text messages from the Nigerian Center for Disease Control. Screening started at the ports and the borders at February 2020. I think I was really proud to really see Nigeria test very early at the ports and borders at early in February, even when I traveled to so many countries and this was not established at the time. So Nigeria was already testing. We also had establishment and development of test centers. This started after our index case in on February 27, 2020. And Nigeria now has 33 test centers with overall capacity for 200,000 tests. And then we also started to establish and develop isolation centers. New isolation centers started to come up, and then we also have started to use our infectious disease hospitals in different parts of the country as isolation centers for COVID-19. The Nigeria Center for Disease Control developed call centers, and at these call centers we had state-registered COVID emergency response numbers where they had telephone and online triage, where there were different questions offered to people, and then after that it was decided whether to go test and pick up patients for the COVID-19. Also, training of health workers and provision of PPE started off in February 27, and the trainings are also still going on right now. There was closure of the ports and borders in March 2020, so as to stop incoming visitors into the country, so as to stop international transfer of spread of infection of COVID-19 at the time. Then we started off also doing contact tracing and isolation of positive patients, and then admission of patients also in the isolation centers. And the isolation centers were being developed, and then treatment protocols and hospital triage were established, where the Nigerian Center for Disease Control, along with the WHO standards, developed treatment protocols and the hospital triage. There was also the enforcement of infection prevention control protocol in public spaces, where we started to have hand washing outside of buildings, development of hand sanitizers, and cleaning of hands was really established. Wearing of face masks was established, and this was one of the things that we started to do. This started off in March 2020. Then we also started, when the cases started to increase, there was a lockdown in Lagos State, which is still the epicenter of the COVID-19 infection. The Federal Capital Territory, Abuja, and Ogun State, we had this lockdown in this state in March 2020. Then the government, as a result of this lockdown, started to provide government palliatives. These were used to support people who had dependence on daily income and low income earning people. These were supplied to people as much as the government could, and the government palliatives were being provided to support people. Then the private sector funding and initiatives started up, where private sector started to help to build different isolation centers in the different parts of the country. There were supplies of funds in getting tests done. There were supplies of funds in trying to provide PPEs for doctors, and this continued, and this has still continued till today. Also, we established the restriction of interstate movements within the country. That was done on April 27, 2020. And then there was now gradual and phase ease of lockdown in the states. There was a lockdown established in Kano, which is one of the states in Nigeria, in the northern part of Nigeria, on May 13, 2020. This was as a result of over 600 cases of mysterious deaths in about 2 weeks. This has come back that more than 60% of these deaths were as a result of COVID-19. And now there's a national ease of the lockdown, which was established on May 2020. We are experiencing different phases to this ease of lockdown. Now, the challenges that we have faced during this period are divided into the people, the health system, and the government. Now, for the people, we have a large population of uneducated people, which is about 60% of the population, and this has made people to have a poor understanding of COVID-19. So there's still that communication gap, even if as much as the Nigerian Center for Disease Control, the Ministry of Health, and other parastatals have tried to communicate this. You can see because of this low education level, people still don't understand the gravity of what COVID-19 is. Also, because of the economy, the people who depend, there's a large number of people who are living on the poverty line. So, and also there is poor accessibility and availability of these government palliatives. So it is quite uncomfortable for people not to work or not to follow guidelines with the lockdown. And this has made COVID-19 quite challenging because of the economy. People have to look for what they need to do and how to feed for themselves. So it's been quite difficult. Also, with the housing part, what we have as a challenge because of the massive population to the amount of isolation centers that we have, we are getting to a phase where people are being isolated in their homes. But this is really not going to be something that we can do because we live in a largest number of the population live in a communal setting where they share almost everything. They share the bathrooms, they share the door handles, they share. So because of these communal settings, it is really difficult to isolate people in their homes, and this will also make containing the infectious or the positive cases. This will make it a lot difficult. As a result of culture and religion, because of different cultural beliefs and some religious leaders not understanding the gravity of this COVID-19, there are different misconceptions that have been sold. And as African people, we tend to believe our culture and our religion more than what we stick to with the scientific background. And this has also made it a lot challenging from the people's angle. The idea of stigmatization came from trying to test people. So when the triage finishes from the phone calls, it's the ambulances will get into the community to probably pick up the patients, and then there's a lot of stigmatization, and there's a lot of avoidance by relations and neighbors, and this has also prevented people from coming out to get tested. Also, people have not been complying with the government guidelines on the infection prevention control guidelines. People don't use the face masking appropriately. A lot of people don't use at all. The hand washing and hand hygiene has become a really tough battle. More than 60% of the or 70% of the population use the transportation system, which is poorly regulated, and as a result of this, you can really not maintain the social distance that is required for this, and so this is really alarming for what we expect from all of this for the COVID-19 pandemic. Also, healthcare accessibility and availability is a bit of challenge. From the statistics I showed earlier, you can see that availability is a challenge, accessibility will definitely be a challenge. So people are taking faster alternatives, going to chemists, going to pharmacies, going to quacks, and these fast alternatives are not helping in any way. It's actually helping to increase the communal spread of the infection. Now, to the health system and the doctors. The health system of Nigeria is a private sector driven, with over 60% dependence on the private sector. There's a training gap and deficit because the Ministry of Health, the government parastatals, the Center for Disease Control are concentrating majorly on the public sector of the health system. And this leaves the private sector in a gap. There's knowledge gap on how to really manage the COVID-19. And so it really takes a lot of investment from the private sector to really fill this gap up. And the private sector drives the health system. So this is also a major problem and challenge that we're facing right now. There's inadequate distribution and provision of PPEs. I think that is a global issue. Inadequate provision of hospital supplies. I think it's all over the place. It's everywhere. Shortage of staff and volunteers, just like Dr. Naidu also mentioned. We're all facing this. It's a critical theme at our time now. Also, we have emergency protocol and response system. Just like I said, we have a poor emergency medical service system, and this has left us in a big gap of what to do. Also, the hospitals are not designed. There is a lot of design error in terms of structure, so as to function normally for this kind of epidemic. So the hospitals are really not functioning, and the structure is not adequate for the kind of infection that we have. This cannot be overemphasized. I mean, the health workers' remuneration and health insurance. So it puts the average health worker attitude to infectious disease is really low, and the attitude to infectious disease is really low. Also, health facility inadequacy too is also one of the challenges that we have in terms of the isolation center capacity and the ICU. At this point, the last Ministry of Health, the Minister for Health mentioned yesterday where he was saying we are getting really above what the capacity of what the isolation centers can hold. Also, we have lack of beds. We don't have enough bed spaces for the critical patients that require respirators, ventilators, or that require ICU care. Okay, so also for the test and the turnaround time of tests, we have been able to do over 80,000 tests for a population of about 200 million people. And so this leaves us as really we are not testing to capacity. From what I shared earlier, we can see that even the government has provision of about 200,000 tests. People are actually not coming forward to test as much. And the average turnaround time of the test is about 72 hours. So even when we get the updates, there are no real-time updates about the test figures. In some places, because not all states, we have about 36 states and the Federal Capital Territory. And as a result, we have 33 test centers, established test centers. In Lagos, out of the 33, Lagos has 8 test centers. So we can see the uneven distribution of the test centers throughout the nation. So in some states, it will take about a week before they get the test results, and this is really a large gap. So, we need to cover that gap. In order to cover this gap, there are faster alternatives that could be the antigen antibody test kits, but the quality control of this has not been well established, and this is still being looked into by the Ministry of Health. Also, we have a poor infectious disease protocol, I think, with COVID-19. Most of our infectious disease hospitals have been rendered redundant for some period before COVID-19. And so the infectious disease protocols are not things that we're really used to. And so we're getting back to the drawing board. And I think the Ministry of Health is really working to get this established at this period. For emergency medicine curriculum and program in postgraduate training. So I think this leaves us at a really big gap many of my colleagues that are from Nigeria, we really admit to this. We do not have emergency physicians as you will see in many other parts of the countries. Just like I am the head of medical emergency there, that is how we have different units, even in tertiary centers for emergency medicine. So we need to improve on that right now. There is a poor triage in the hospitals. About the poor triage, where the challenge leaves us is because every case is being treated as a COVID-19 case. This has left many patients abandoned even when they don't have COVID-19. And as a result of that, it has left a lot of people even die from many other causes than COVID-19. So the triad system is not adequate at the time. And the doctors are trying, but yes, infectious disease control protocols are also some of the limits that they have. And this is still something that we're developing and we're working on seriously. Then the management protocol for COVID-19 has been changing and it has been changing over time. And this is one of the limitations that the health system has now. And I believe globally we are developing further, getting better on the protocol for COVID-19 management. Also, from the health system, we have rivalry in the health sector where there is a private sector competition, not really healthy competition, and public to private bureaucracy, where the gaps that the private sector are willing to occupy because of a lot of bureaucracy, the public sector is not allowing that to happen, and this is really creating some issues at this time. Also, I then need to mention that there is increasing communal spread of infection to low, and this is the ratio to the capacity for treatment is really low. On terms for the government, where the government has the issues, it comes to the population size. For our infrastructure, the population size is really massive for what we have as an infrastructure for our infrastructure, health infrastructure, and this is something to really to develop, and we need to develop this rapidly. The economy is not at its best now. We are crude oil dependent, and at this time, this is not the best time for crude oil at the moment, and so the economy is also the government is facing economic issues at this time. Plans for health emergencies and development of emergency medical services. I think from all the things I've stated earlier, that can explain that we need to develop better plans for health emergencies and develop our emergency medical services. We actually need to develop the field of emergency medicine so that it can speak and it can help with managing situations like this. Also, politics. There are still a few states that are still in denial of and playing politics with COVID-19, saying COVID-19 doesn't exist, it doesn't exist in their states, and it's being turned to some political things, and this is not healthy for the population or the indigenes of the states at this time. Also, there are multicultural and multi-ethnic distribution because of our multicultural and multi-ethnic distribution. Different cultural things, like I mentioned earlier, are still being are still serious issues that we're going through. Palliative distribution, I've mentioned that earlier from the government. It is unevenly distributed. It is small to the population, so people really are um, losing guards on how to protect themselves with COVID-19, and the poor understanding is making it worse. Adoption of management from other countries. Uh, I personally feel the lockdown in Nigeria was quite early. I think this is about the period where we should have had the lockdown because the communal spread is really increasing. So we just started lockdown just as so many countries started lockdown. And this leaves us now, because of the economic situation of the country, people cannot afford to go back to have a lockdown. Life has to continue. And so we need to have an individual plan, a country plan on the management of this going forward. Also, there's a cry of the communication gap from the task force, Ministry of Health, and the Center for Disease Control on what is going on about COVID-19. A lot of people still feel that communication gap between the population and the citizens of the country and the task force on the management and the situation of COVID-19 in the country. The experience for clinicians. COVID-19 is a novel disease. It came with a lot of uncertainties, um, uncertainties in terms of clinical presentation, uncertainties in terms of treatment guidelines and protocols. I'll share a personal experience of when we had a patient coming to the hospital. The patient had been rejected from different centers because of suspicion of COVID-19. And so, as a result of trying to find a way to manage this patient who had an elderly patient who had come in with a CVA and had hemiparesis, and so we wanted there was a need to help. So we used some of the um, basic investigations from the full blood count, the D dimer, a CT scan, and these were the things that we used to find out some of these things. And it was from the chest X-ray and the brain CT that we were able to transfer the patient to the infectious disease hospital at this time. Now, because of the uncertainty at that point, the thromboembolic um, complications of COVID-19 was not really established. So if we had taken in the patients, it would have become a serious problem for the hospital. But because we had a waiting area or a holding area where we could still manage and keep the infection minimal and avoid spreading to the hospital, we were able to contain this and we were able to transfer to the infectious disease center. So because of these uncertainties and the clinical presentation, quite a lot of things um, we're not getting as we should get. Also because the turnaround time of the test for that kind of patient who presented with a stroke, what do you do? Do you wait for confirmation of the test before you start managing? So those are some of the issues. Infection control structures, like I mentioned, and the PPEs, it has been an issue. I like some of the things that Dr. Vanessa mentioned about the population to the PPE, and these are some of the things that are now being adopted to manage the PPEs and the hospital supplies in order to control management and prevention even in the hospital. Also, the clinical trials about different types of drugs and medications that can be used and symptomatic management of patients are still some of the dark areas for clinicians, even in management of COVID-19. So many hospitals do not have holding areas or wards for indeterminate cases, just like the one I mentioned earlier, that require admission. And some of these patients have pre-existing conditions, some do not have pre-existing conditions. So we need holding areas to hold them and manage them while we're trying to confirm if these cases are COVID-19 cases. Also, to treat every patient as a COVID-19 case has become an issue, and so many patients have been abandoned. And the ones that have not been abandoned, where the doctors have not established good infection prevention control, so many health workers have been infected. Also, there's poor collaboration by other clinicians. So once a patient is tagged as having COVID-19 or as confirmed as having COVID-19, it is then difficult for you to get the help of other specialists apart from the emergency medicine doctor and the infectious disease specialist. It is now difficult to get even the pulmonologist. I think majorly the intensivists, the emergency medicine, and the infectious disease doctors are the ones at the front line. It is really difficult to get other specialists to get in because they are afraid of being infected, even when the PPEs are supplied. And this comes to the psychosocial support that the health workers and the patients need. Because the health workers goes home every day thinking of not taking an infection onto the family members. So we need a lot of psychosocial support for each one, and also for patients that have recovered or that are going through the having the infection who are still having active cases. they need psychosocial support. And in case of the medical insurance and remuneration and motivation, I think this will help also when the doctors are feel safe or the health workers feel safe with medical insurance, adequate remuneration, and there's good motivation. This will also help in establishing total commitment to the management of patients with COVID-19. So, in conclusion, I think we all have a responsibility for the COVID-19, for the containment of COVID-19. The people, the health system, and the government need to wake up and fulfill their responsibilities. We have to take each one for all and all for one. We need to improve our emergency preparedness and capacity in infection disease control. We need to continuously develop capacity in research and healthcare even after the pandemic. We need to develop scientific strategies as it applies to managing our healthcare problems in individual countries and as a country. Thank you.
Thank you so much, Dr. Idowu, for that really informative presentation. It's really interesting to see the ways in which Nigeria, South Africa, countries all across Africa are responding to COVID-19 and the similarities and differences in terms of challenges and the ways that we're facing them as a continent. So that is the conclusion of our webinar. We seem to have no questions for either presentation, which just goes to show how fantastic and informative our speakers are. So thank you for giving that presentation and for being at the front lines of the fight against COVID-19 in Nigeria.